Good afternoon, everybody. I hope that the hyperglycemia after lunch doesn't lead you to sleep. So my lecture is going to be more visuals, less theory. I have no financial interest to tell you. In our type of practice, the angiography and OCT is a navigator to management of diabetic retinopathies. These modalities have changed the understanding in all the studies. Now we have a pre-OCT era and a post-OCT era. So OCT is becoming essential, whether it's background diabetic NPDR or PDR. They are complementary to each other. And if you have both facilities, always do both of them. Huge list of findings in diabetic retinopathy of FA, but the indications are there to look for the areas of leakage for laser in the focal, look for NVD, NVs, and look for ischemia. So there's three factors you need to see. If the diabetic retinopathy is a clinical diagnosis, you do the fluorescent angiography only when you suspect a NV, NVD, you want to confirm it, you are planning a laser for CSME and you want to know the focal leakage areas, or you have an unidentified vision loss, whether it's ischemia or ARN, which is there with the diabetics. So this is the only finding which you will not see clinically, the ischemia. See the capillary non-vision, there's total dropout areas between the vessels, and you can see the venous bleeding and the macular ischemia. This patient may not have too many clinical findings, but the angiography will help you. This is the only ideal case where the fluorescent angiography helps you over clinical finding. As I mentioned, the indications are limited. Treatment for CSME, finding the cause for unexplained vision loss, identifying the areas of non-perfusion, the edema, and in doubtful when you have NVD, NV which you can't pick up clinically, you doubt it, you require fluorescence. So every patient of diabetes does not require at every foot an examination. So, and it's not needed to diagnose CSME. In CSME, you can do an angiography 3 months or an OCT to look for edema. And even if you have a patient of CSME who has no NVD, NVD, I would recommend that as a clinician you may miss the NVD, NVs. Once a year, do an angiography to pick up NVDs, NVs. Many times the follow-up patient is doing pretty well with a focal laser, ends up with the NVD, NV which you would have picked up on a regular angiography. Though the books will never tell you that the angiography is essential, but I am telling you in a clinical practice, if you pick up an NV, try looking at that area, you may still miss that area clinically. So angiography will help you clinically pick up an NVD, NV much earlier than your clinical diagnosis. Here's the patient, again the ischemia. You may not, it's featureless, but you find a lot of findings coming in. So clinically, if we just do direct ophthalmoscope, we'll just see this area. You see nothing is there. So an examination of the clinical picture requires a good fundus opinion. Just a direct or a 78D will not work. You need to see the periphery also, and then the angiography will help you. As I mentioned, small NVs on regular follow-up of CSME patients is up. You will just see this area. So you need to look up the up areas also or do an angiography. And when you do an angiography, you must do an angiography of all the fields and you will not miss an NVE. There are certain situations when the angiography gives you better clues in the clinical, asteroid hyalosis. Because in asteroid hyalosis, the picture is totally hazy, you can't see the retina, but surprisingly the angiography photos are not hampered by the asteroid hyalosis. You have a patient with unilateral vitreous hemorrhage, the other eye you don't find a cause, there's no NVD, NV, do the angiography, you might find a NVD, NV. Or if you don't find anything in the other eye, then it might be just a BR view in the other eye causing the vitreous hemorrhage. And post-cataract surgery, in today's world, OCT is preferable, but the assessment of macula can also be done by the fluorescent angiography. See this patient of asteroid hyalosis, you can't see the retina, but on the angiography, you get a better picture. So asteroid hyalosis patient, definitely, angiography is easier, but when you do a laser, again it's difficult to focus on the retina. Similarly, a featureless retina, the macular ischemia will be picked up only on the angiography. So when do I follow up? When I do a laser, the follow-up today world is an OCT, but you can do at the end of 3 months the angiography to look for the regression of the leakage. Remember, the one line which I tell everybody is that the ETDS studies quoted that an average focal laser will need to be repeated 2.5 times before you have regression of the focal retinal edema. So please don't think that you've done a focal laser and the patient is going to regress. There will be points which you have not done laser. You may need to repeat the focal laser 2 times, 3 times, and don't tell a patient that one laser will be effective. Tell them at the end of 3 months, I will do the laser, fluorescent again and look for the leaking points. If they are still there, I will do the laser again. And the other thing to note is that when you do a PRP, the regression is never complete. Only 50% of the patient will have total regression of NVEs. There will be small NVEs, NVDs which will not regress. Should we keep on doing laser? So you must know which patient is regressing. You can hold on. So you need to do angiography after 3 months. This is a patient of focal laser, leaking microaneurysm severely. Then the laser is reduced. So sometimes in the foveal area you do see a very severe leakage, and it may be just a focal macroaneurysm also with it, which you sometimes diagnose as NVE, and you end up doing a PRP. This is a patient pre-laser. You do the PRP, it doesn't regress, then you can do focal laser. If it's not regressing after 3 months, then you can think of doing a focal laser, post-laser, and direct burning. But never try direct burning a patient. Sometimes what happens is the fluorescent angiography will show a leak, but the early phase will not, and it's just the fibrotic tissue has a late staining. So always remember that every leakage is not an NV, it might be staining, and always compare the early phase with the late phase to have an idea what the lesion is. In an angiography, never make a diagnosis singly on one picture. Here again, a patient with NVs, and you must keep regress. See, normal photograph you take like this, and you tend to forget the peripheral photographs. So always all zones look up, right, left, down, and as peripheral as you can go, do the angiography. Now coming to the OCT, which is a new tool. Remember, it checks the thickness, it checks the lesions. So when you see an OCT, I look for the thickness, the changes at the vitreoretinal interface, and intraretinal abnormalities. So you're looking for 3 things. Whether it is different types, all OCTs will give you a clue in diabetic retinopathy. Normal OCT will show a normal thickness of about 200 microns in a normal retina. Each company will have a different, spectral will have a different thickness. The clinical significant macular edema you pick up when it's approximately 300. So you are now having a new diagnosis of OCT based edema, where you pick it up on the OCT much before the clinical significant macular edema. So in the latest study they're going to come out which says treat this. At the moment we have no randomized trial to say that you treat this part of the edema. And especially we have more thickness than 400, that discussion will go on whether to give anti-VEGF or steroids in diffuse diabetic macular edema. So on fluorescent angiography, you diagnose focal or diffuse. In diffuse, you tend to go first towards anti-VEGF. As Dr. Ajay showed you a trial where you may give anti-VEGFs or steroids and then do a laser later. For focal patient, you do a focal. And for focal, you may not require an OCT. So people who do not have access to OCT in their surroundings, if you have a focal laser, you can do a focal laser. If it doesn't resolve, then you can refer for an OCT. So the indication for an OCT is CSME, any unexplained vision loss, or you're suspecting a vitreoretinal interface problem. And the role, as I mentioned, is complementary to FA and does not replace. And the various types of lesions on diabetic macular edema which have been noted are the spongy thickness retinal edema, which will resolve to laser, the CME where you may require a posterior subtenon or intraocular steroid of anti-VEGF, subfoveal serous detachments which are not picked up on the fluorescent angiography, or you may have a taut posterior highlight. I'll just show you a few examples. A spongy retinal edema, you see the edema, diffuse. Or you may have the cystoid, and these patients respond poorly who have atrophy towards the photoreceptor side. So this edema is more dangerous than this edema because the edema around the photoreceptors will cause more damage. Or you may have the serous detachment here where you find no leakage on the fluorescent. So the fluorescent will miss these kind, and you do a focal laser, they don't improve. These one you will diagnose with fluorescent angiography. So basically it's reproducible, you can do the mapping and then to monitor the edema. Here is a case of hypertensive retinopathy, patient having nephropathy with having a serous detachment. You may miss it out on the fluorescent and you don't need to treat this patient in the beginning. Unexplained vision loss diabetic, you may have a PED. This was a diabetic patient with unexplained vision loss. We couldn't explain. They had focal leakage here but had a PED. Patient had a ERM. You couldn't explain the vision loss in diabetics. So sometimes you have associated pathologies which you may miss on the fluorescent or the clinical. Again, example of a focal leakage, but you do the patient has edema. So sometimes the OCT picks up what the fluorescent cannot. This is a serous detachment before the tricot and after the tricot. Or intravitreal, it may not resolve fully, it may decrease. So the idiopathic CMEs with just a single mechanism will be picked up on the OCT. Laser was planned, but you see the OCT having a traction is the disc, edge of the disc, and a tractional causing a serious detachment here. So this patient is not going to respond to laser but a surgery. Similarly, the leakage you can see at the fovea. So these few examples I'm just showing you where the fluorescent and the color photograph may not give you too much clue, but the OCT gives you a clue. So the OCT, again here, look at the patient. The fovea is dry. Vision loss is still there. The serious detachment. So when you have an unexplained vision loss, this is helpful. A regular focal patient, focal laser done, has the edema, resolved just with laser. So you may have these patients who will resolve purely by focal laser. Or you have a traction where surgery would be required to relieve the traction. The next speakers will be elaborating on these. Patient of PRP, you've done a PRP, so every post-PRP, if he doesn't have 6/6 vision, doesn't have macular ischemia, then the problem is the vitreoretinal interface. You find the vitreoretinal interface creating a problem. Now if this patient has a small NV and you do laser, this will be aggravation. Again, before the PRP, you see the epiretinal membrane coming off. The laser precipitates epiretinal membrane formation, and you see the epiretinal, it will require a surgery to relieve the traction. Post laser, patient has vision loss, the serious detachment picks up after the laser. So too much aggressive laser also can create problems. So just dioptric retinal follow up every 3 months, and if the conversion of NPDR to PDR, when in doubt, do FA, and unexplained vision loss, you do, or CSME, do the OCT. Thank you very much for your patient listening.